Hi, I'm going to start doing my presentation on type 2 diabetes, mellitus, and hypertension on my patient. My name is Lydia Collison, and this is nursing 442. Okay, my patient is AH. She's a 32-year-old married, pregnant, Hispanic female. She is a homemaker with 7 children at home, with the oldest being 14. She currently uses government resources such as cash aid, food stamps, WIC, and Medi-Cal. She recently moved to California from Utah to help take care of her ailing mother and father and her spouse's mother and father. Her and her family do not live in her own home, but they live in her husband's parents' house. Her chronic illnesses include type 2 diabetes for 8 years. She uses oral medications, metformin 2 times a day, states that she has good control, but her H1C is 7.8 and her incoming blood sugars are in the 230. She is placed on an insulin drip to monitor her blood sugars between 80 and 100, which is best practice for pregnant women. She also has hypertension, which she has had for 5 years. She uses labetalol 2 times a day, and her blood pressures on arrival were 185 over 105. That is considered eclampsia, preeclampsia, and we're going to manage those right away. She is also in preterm labor because of these pre-existing conditions and the fact that they are out of control at this time. So self-care capacity, she can perform all of her ADLs by herself. She can take care of herself. She does have the limited ability to eat nutritious food because she is on supplemental income and, well, not supplemental income, stuff like cash aid and food stamps. So when that runs out, there's not a whole lot to choose from, and fruits and vegetables are expensive. She has limited sleep. She's pregnant, as well as living in a situation where everybody sleeps kind of together. So she takes frequent trips to the bathroom, which interrupts her sleep. She is able to manage her medications if she wants to. She does have high-risk behavior use, including marijuana, as her urine drug screen was positive. She does live with family members, but she takes care of them, so that doesn't limit her care capacity, and then they only do have 1 car for the family. The priority issues for discharge planning I found were medication adherence and fetal monitoring. So those are going to be the things that we're going to talk about the most during discharge planning, because she needs to take her medicine to not put her baby in danger, and we need to monitor the baby because of the medication reactions. And if she's not taking them, it'll be dangerous for the baby. And even if she is taking them, sometimes it can be dangerous for the baby. The patient can be discharged home. She won't require a higher level of care than she came from when she was discharged. The priority case management strategy at the patient and system level. For the patient, I included education, family dynamics, and praise and reinforcement. And at the system level, the priority strategies are referrals, follow-up appointments, fetal monitoring, and financial assistance. Interventions at the patient level, we have education. Of course, education is going to be involved because she needs education about taking her prescribed medications and the effects that not taking them will have on her baby. She also needs education on making sure that she goes to all of her appointments and everything on time. We also need to find out more about the family dynamics to see if there's any stress involved with her living with her relatives, or if anything else can be done to help them get in their own place while still assisting their other family members that need help. And then she also needs praise to, reinforce that she is a good mom, as this is her 7th baby, but that she just needs to take care of herself so that she can have a healthy baby. At the system level, she certainly needs referrals. She needs referrals to the Sweet Success program to manage her diabetes. She's going to need a referral to a primary care provider to manage her hypertension. She's also going to need to make sure that her follow-up appointments are set up with her prenatal care provider. She will also need fetal monitoring, so she'll need referrals for NSPs twice a week. And then she will also need financial assistance referrals to see if there's any other government programs that she can utilize to help them become a little bit more stable at this time. For utilization review, for her healthcare utilization, she doesn't have a primary care provider because they just recently moved. Her only other hospitalizations have been for birth only. No other surgeries or hospitalizations or any other visits. And then She does have non-adherence to appointments, as she already had an appointment for the Sweet Success program and didn't attend. Our quality issues are the education given and the education retained. We need to make sure that the education being taught and handouts being given are at the 5th grade level. And then we need to make sure that she's actually retaining information and repeating it back, or she understands where to go to get further education. For safety, we are concerned about the safety of the fetus as well as the safety of the patient. And that includes medication management. So the effectiveness at the patient level, if we ensure education and ensure she has transportation to and from her appointments, ensure that she can get to and from her prescriptions, and we ensure there are no other patient needs at home, we will be pretty effective in everything that we do at the hospital to get her normal stabilized and then send her home with this education so that she can manage her chronic diseases for the last 8 weeks of her pregnancy. For the effectiveness at the system level, we need to make sure that all these people get involved. We need to make sure that she has PFS consults and they're documented, and she has the handouts and the programs given to her that can help her and her family further. We also need to make sure that she has her follow-up appointments, either with transportation and with her doctor's visits, or that she has verbalized that she has transportation to these visits. We also need to make sure that we set up her first fetal non-stress test to make sure that she has that appointment available and that we're not relying on her to set up this appointment. And then we also need to reset up a Sweet Success appointment and send the referral over so that she has it set up, and if she chooses not to go, we can also document that as non-adherence. And these are the references that I used. Thank you for watching.